This is the MRI scanning of a patient who has presented to us with a large pituitary macroadenoma or a Sellar mass, so to say. This patient has a history of surgery 20 years back through the transcranial route on the right side for a pituitary lesion, post which we developed right side complete blindness. Now, and following the surgery, he underwent radiation therapy for the mass as well. Now, this patient is presented with left sided blurring of vision as well as progressive headache for the past 2 years. On examination, we see a large sellar mass with suprasellar extension with a Knosp II classification, that is partially Knosp II or 3, that is partially going around the cavernous carotid to not completely encircling it. The tumor plane with the carotid is still maintained. There is no wall irregularity or compression. And with the right eye already blind, we pick this patient for a revision surgery, transnasal endoscopic binostril. However, in this situation, since this tumor is predominantly more on the left side as compared to the right, and we would require a larger access on the right side, you would use a 1.5 nostril approach in this patient, which would be using the one nostril on the side of the maximal lesion completely, whereas just using the septal flap on the other side in a septoplasty incision and not contacting the lateral nasal wall, so as to preserve both the posterior septum on one side as well as the anatomy of the olfactory fossa. So once on the right side, where we need more superior as well as the lateral access for the vasculature and near total removal, we have gone not just on a midline sphenotomy, but through a standard approach converting in uncinectomy, enterostomy, and complete ethmoidectomy. The ethmoidectomy here is very important because the tumor has a suprasellar extension, and for suprasellar access, we need to have the entire foveal roof in picture and not just the sphenoid. The sphenoid has been completely open now. You can see that there is a bulge inside the sphenoid sinus that bulges off the sellar mass. And now with that bulge in picture, we are using a Kereson's punch to progressively enlarge the sphenoid anterior face right to the planum sphenoidale, and we'll keep coming back towards the ethmoidal roof so that we have the entire foveal roof that moves towards the planum in one line of action and line of sight for both visualization as well as for comfortable instrumentation. The Kereson's punch is a very safe instrument for progressive bony resection. We get to palpate the amount of bone ledges left, and we can take very sharp bites. Smaller bites are advisable than very big bites so as to avoid avulsing any bone or any critical neurovascular structure that is attached to it. So we are going progressively superior till we hit the flat bone of the planum sphenoidale. On the right side, we have very little to lose since the optic nerve is already gone since past 20 years, but the internal carotid is still intact. More important that one has to understand in these patients is this has been once operated as well as post-radiation. So in post-radiation tumors, we generally avoid being too surgically aggressive. These tumors can be variably fibrosed, can be adherent to the internal carotid, and any unnecessary avulsion or pull on these tumors can lead to significant injury or internal carotid ruptures. Using the bipolars to basically coagulate the septal branch of the sphenopalatine artery that comes on the anterior face of sphenoid. Here on this side, we will be lowering the face of sphenoid much more. So we need to occlude this vessel for complete visualization. As of now, we do not have any plans for any flap raising on the right side. If need be, we can do it on the left side to close here. Also, because of the fact that we want lateral exposure, we are not contemplating any flap raising on the right side because we have to go laterally, even sometimes to the extent to the digoids, to gain a sufficient exposure. Once a reasonable amount of sphenotomy has been completed, now we are ablating using a coagulation wand the posterior part of the septal mucosa on this side, progressively one by one, firstly initially a little bit and then probably more as we go forward, because this part of this septum will go. But mind you, we said that we'll do a 1.5 nostril approach in this patient, so we will only ablate the septal mucosa on that side and we will remove the bone on this side, but we do not want to ablate the mucosa on the other side. So the septum in its mucosal integrity remains completely intact uh, on the left side, only the bone being removed so as to not cause any cross scarring or loss of olfactory function on the other side of the septum. Now, this helps us gain a reasonable access, being the larger side on the right side, that here is the side of bigger exposure, as well as just giving us good enough space for instrumentation from the opposite side, whether it is the endoscope or the instruments, and also avoids the mobility because practically we do not contact the lateral nasal wall at all. Now you see that the sphenoid, we have placed a saline soaked Medocell patty in the sphenoid while we are using our ablation onto the posterior part of septum on the ipsilateral, that is the right side. We go high up to the planum. And now that that access is somewhat done, now we initiate the surgery on the left side. And like I said, left side, we will not go ethmoidal. We will go septal. So we give a septoplasty incision, the Freyr's incision, and we will elevate the septal flap, and we'll take down the posterior septal bone. But at all times, we will maintain the integrity of the septal flap so that it is usable in case we need. In case of a large CSF leak, we can use it into a flap almost immediately, or we can just put it back and suture it like a septoplasty incision, thus avoiding any trauma on the lateral nasal wall, any synecdoche formation, and leads to a very, very fast recovery. So you see, we are in the septoplasty incision. We're using an endoscope for the septoplasty incision. If somebody wants to use a headline, that is quite all right as well. Any approach is good as long as we understand what we are doing. Now see, we have now come to the rostrum, and what we are doing here is we are elevating the septal flap of the rostrum and displacing it laterally so that we can access more of the rostrum. And once we remove this rostrum, we get to have the sphenoid from both sides, on the right side on a total way, on the left side in a half way, which means through the septoplasty incision and not via in contact with the lateral nasal wall, thus conserving the lateral nasal wall in this kind of surgery. Also conserves the septal flap on this side because we do not take off any septal mucosa on the left side. We'll put this entire septal mucosa back just like it is. One can use drill for removing the rostrum or sphenoid. However, in the interest of time, we normally prefer to use a chisel hammer. It's quite quick. There's nothing much to worry here. We use some quick strokes, controlled strokes of a chisel to at least subtotally get the rostrum out. And once we do so, the rest of the part can be done with a standard nasal skull-based drill. You see here how we have come to the planum. The sphenoid face on the right side is nearly completely exposed along the complete height from the floor to the roof of the sphenoid sinus. You see on the right side there is a huge bulge. That bulge itself is the Sellar bulge caused by the tumor. Now we are using a shaver blade to just ablate and eat up the intrasphenoid mucosa on the left side. We are not resecting the septal flap, mind you, and one must be cautious not of doing so. And once we can see the intersphenoid septum, we start using a drill to start drilling the intersphenoid septum. And we don't avulse it ever because it attaches to the carotid or sometimes to the optic nerve, and it's avoidable. It's straight in this patient, but more or less it always is not. It's never straight. So the use of a drill is strongly recommended. The starting part of the drilling can be done using a cutting burr. I don't think anything is wrong with the cutting burr in the front part of the drilling as long as the control on the drill is good, which means the central part of the intersphenoid septum, the base of the rostrum or sphenoid. In fact, a little bit inferiorly as well is all okay with the cutting burr. And once we come to the actual drilling onto the sella itself, or when we go superior and laterally, probably then that would be a good time to switch to a coarse diamond or a diamond burr and not use a cutting burr. You can see that now we can see how the bulge is sort of oblique, more on the right side as compared to the left side, and we're removing the sinus mucosa completely and pulling it off. Now we have switched to a diamond burr once we are going close to the sella. A diamond burr makes our surgery slightly longer, but also makes it safer. In case of an accident slip on the burr, we do not risk injuring any critical structure. In between, one can obviously use the bone punch as well to remove any sharp places of bone. It's quick. It doesn't cause any bone dust or heat. So, and doesn't require many hands. As of now, we are just using 2 hands only within the bone punch to sharply cut through the intersphenoid septa in the bone and not avulse it. And post that, once we have some more space, we use the drill by drilling the entire base. So what we want to achieve here, what is the limit of drilling, is basically being able to see the floor of the sphenoid sinus and the clival recess. The clival recess, mind you, has been completely compressed because of the size of this cellular lesion. So in a compressed clival recess, we have to, what you can see down there, we have to expose it because we have to find the floor of the cellar, completely expose it before we try to open the cellar periosteum and the dura. And as well as laterally, though we are not going transpterygoid here, but we are using every bit of the ethmoidectomy space that we have created to drill laterally towards the orbit to get maximum space for not just drilling, tumor manipulation, as well as being prepared for any contingency in case there is any vessel rupture due to any inadvertent injury. The first thing you want is space, and to prevent or even put a muscle patch or something like that, because if there's no space and you operate in a blind, in a small hole, that is recipe for a disaster. You want to make all margins flush. You can see that we are going on the planum, drilling completely because has a supracellular extension. So we are drilling generously to make all the margins smooth and flush. We want a clean, flush cavity with no overhanging edges, because they're not just the overhanging edges and ledges of bone don't just impede vision; they also significantly impede instrumentation, because most of the instruments we use here are straight, and that's how it's supposed to be. Now, once we've done that, you see we're using a fine diamond burr to basically just thin down the cellar bone. We expose the floor of the cellar. You can see that. So using the diamond burr to thin down the entire cellar bone um, uh, in toto, not making very thick bone, because thin bone can be completely removed. In between, we use a simple blunt palpator or a blunt raspberry to keep feeling as to how thick the bone that is still left. We can see some sphenoid mucosa still lying on the left side, which still has to be removed as it is little down. We can use a curved curette to push and peel this mucosa off the floor of the sphenoid sinus. We can see how a very compressed clival recess lies there because of the push of the cellular lesion from above. What that means is that we need to drill more of the floor of the sphenoid. So again, we come back to our cutting burr to drill more of the sphenoidal floor, so that we have a reasonable amount of instrumentation possible. Now you see that what we have achieved by drilling is that we have made the clival recess open. You can see the indents of the paraclival carotid on the right side already. We don't have to do much with that, but we can see the completely open and bare clival recess after removing the mucosa from there as well. Back to the diamond burr, and again barely flushing all this bone over the paraclival carotids as well, just for any possible preparation in case we have to mobilize the vessel. So for most part, that is not part of the plan, because this is as I had discussed, this is a post-radiotherapy tumor. Our goal is just uh, near total or subtotal resection only, and followed by histopathology, and then discussing if we have the ability to re-irradiate this patient. But surely we do not want to be too adventurous, because we know that in a patient who's already had radiotherapy, these tumors can behave very, very differently intraoperatively, and major vascular injury is a very, very real threat and risk. This is a part of the surgery that requires some patience. It's always not present. It takes time. We got to thin down this bone. One can also sometimes do a little tap on the osteotomes or the respiratories, but that's rather crude method. I would avoid that, especially in this kind of patient with a vessel uh, p- pretty much free inside the cavernous sinus. So we would use a diamond burr only. As you can see that we are um progressively thinning the cellar face all around to make the bone thin, because thin bone can be chipped off, can be bitten using a Carrison sponge. You can see now 3 hands are in place. One hand is always suctioning and irrigating, and the other 2 hands are holding the scope and the drilling. Now, once we have seen that we have exposed the periosteum, now we can start chipping off the bone of the Sellar progressively. We always begin in the center and move laterally. As we move laterally, of course, we would be using the Doppler as well to uh, approximate our location of the carotids. The CT navigation, unfortunately, in this space placement we were using is of not much consequence. In this instance, there was some technical issues in uploading of the MRI films in the navigation systems that left us in a little bit of a dilemma because on a CT, we didn't do a CT angiography. It was a uh, um, non-contrast CT, I think, and that really does not show any interface between the tumor and the carotid, so it's of not much value here. And the MRI was not getting loaded. So when this kind of condition arises, all the more important it is to have a more larger than usual exposure to be on the safer side and use the Dopplers multiple times in between the surgery to approximate your location of the stellar carotid artery so that you do not do any inadvertent instrumentation there. As you can see, we have been removing some of the bone. We again, since I said now this is a Doppler probe, trying to figure out the approximate location of the vessel as to how lateral that would be, because that would also dictate how and where we place our incisions onto the cell walls. Once we have exposed a fair amount of the periosteum of the Sellar, just use some bipolar brush strokes to coagulate any surface vessels that would be lurking inside to avoid any bleeding. And then you would start by giving an incision, standard cruciate incision in the central part of the dura of the Sellar. Now, the incision could be anything. Some people like to use a U-shaped inverted or a standard U-shaped flap. Some people don't like a cruciate incision. It's rather variable, and I think it's more or less surgeon dependent without any specific issues with any one incision. Here we're using a sharp retractable sickle to open the Sellar dura in the midline vertically, followed by there will be an incision horizontally as well. And this is, well, I normally feel that this is a good trade-off when you're trying to be cautious about the vessels and the vasculature on the lateral side. You go and you keep decompressing, and in case you want, you can always increase the incision using a scissors, depending on your comfort levels. Once you open the Sellar, and once you open the Sellar, you also get into the tumor consistency and how it's behaving. A very hard or fibrous tumor should obviously be probably best left without done too much, and just with a biopsy. In this patient, we don't even have a biopsy report as to what it is, given the fact that this was treated 20 years back in some other institute. And you can see now how we are going on to the horizontal side as well, making a complete cruciate incision. Once you make the initial limbs, we can always use our standard microsurgical scissors, endoscopic scissors, to widen the incision, followed by actual addressal of the tumor. We'll see how we are going slowly, progressively deeper and excising. It's prudent to take care of the bleeding at every possible step so it doesn't become a big issue as we go towards the actual tumor part. So we prefer to use some bipolars, or in some cases it is just venous ooze, to use a little very small cottonoids or a little patty of Surgicel or gel foam to be kept on to slight oozing, because sometimes once you are inside the Sellar, inside the tumor, even this small issues of ooze can rather frustrate you by causing repeated bleeding inside this area, and obstructing the field of vision, wasting time. So it's a good idea to keep managing any more than usual ooze that you see in the surgical field before you come to the most important part of the surgery, which is going inside the tumor. Now, as we have given the incision, we're using a blunt elevator to palpate. As you see, the tumor is slightly fibrosed. It's not something that just starts flowing out of the incision as one would have it in a primary case. So yes, it's a fibrous tumor. We understand that it's post radiation therapy, though there's thankfully no history of taking of any drugs like bromocriptine, because then that would become an additional risk factor in terms of its overall adhesiveness to the surrounding dura and the internal carotid vessel. Once again, using the Doppler to mark the locations of the carotids on both sides. And once we know that we are safe and we're not getting any pulsations, we could probably, use our second knife to gradually, slowly open the sellar dura to get access to the tumor, which we now can see in front of us. So obviously using all four hands here is very important. One hand could just retract, one hand could simply cut, and that makes the job far easier than one hand itself. And you can see that how we are coming from inside the septal flap, which obviously saves any trauma to the other side of the lateral wall of nose. You keep taking biopsy specimens. It's a rather mildly fibrous tumor. Again, at no point do we pull blindly. We'll take very, very small samples for biopsy initially on a very small tumor biopsy forceps. And now once we have access to the inside of the sella, we can see that now. And now probably we could start slowly and progressively scooping out the tumor, gradually making more and more space for us to move inside as well as to see inside this sellar cavity and not doing anything in a blind way. So, again, one has to be very, very measured about the suction we use. The suction could be the best friend as well as the biggest enemy as well. The suction we are using here is skull base suction, which is tapered all the way from the base to the point of contact. It is olive tipped and it has a large thumb control, a variable thumb control. It basically makes it a very, very controlled and weak suction, but we reserve it for all critical neurovascular issues such as the sella or to the lateral skull base surgery where we are playing around cranial nerves and dura, so that it does not end up sucking aggressively any structure which we don't want to. It's a very mild suction. It's controlled. And like I said, the controlling of a suction and the right kind of suction is very, very important in this step. And one must not ignore it, or one must not use hasten of the surgery by using a large suction without any thought process. And that could significantly injure by pulling the entire tumor down as well as pulling the diaphragma cella down by the suction force and thus causing a CSF leak. Now, you see here we are again constantly pulling slight amount of tumor, very slight amount of tumor, and the amount of the tumor that we are pulling is basically the tumor that we are first dislocating from the use of the ring curette slowly and steadily, so that it's only the free lying tumor or the already dislocated tumor that we can remove and not pull anything that cannot be pulled, because then that obviously is something that can lead to a catastrophic complication in this part of the uh, body. One must again be cognizant of the fact that once you feel that the bleeding is a little too uncomfortable for you to have a good look inside, one must use irrigation. One can also temporarily just put a little cottonoid here and wait for 5 minutes. It generally is good enough to settle that, because it's all, after all, slight venous ooze. This is not any major vessel bleeding. So one should take time and use frequent irrigation, as well as sometimes we have required cottonoids to be able to visualize better inside before any instrumentation. Needless to say that this is a two-man job. This is both the ENT and the neurosurgical team working together in tandem. So one has to be both the members have to be, whoever is holding the scope and whoever is the one who is instrumenting, It doesn't really matter so much as long as both understand in what step of the surgery are they, and what kind of movement control and instrument control is desirable of them at this point, because the endoscope must closely follow the instruments for the surgeon who is holding the ring curettes to keep to have a good visualization inside the cellular cavity. And at any point of time when you feel that a certain part of tumor is too firmly attached, probably it could be even left alone and without any stubbornness to excise it. It's always better for the assistant or someone who's there with you in the surgery to keep irrigating at time when you see some fogging, and not remove the scope each time, because each time once you remove the scope and put it back, it can again be fogging, and that ends up using a lot of time. So it's better that the moment there is some kind of fogging in the scope, it should be a prompt irrigation, gentle irrigation to clean the scope and optics, and for the surgery to maintain continuity without any stopping in between. Now, after a little while, once the central part of the tumor has been removed, one obviously cannot access the lateral part without using either even larger exposure or using an angled endoscope and angled instruments to curate out uh, the more parts of the tumor that are more towards the angles laterally, especially on the right side, as compared to just moving in the center. So after a while, it becomes important either to extend the incision and visualize more laterally, or to use an angled endoscope inside the cellular cavity to be able to access the lateral part. Since our goal is to more or less not do a complete removal in this kind of case, we would rather keep the sphenoid as as such, and not decrease it a lot, because that helps us get a better closure with our fascia and fat strip. And now, as you see, we're using an angled endoscope, a 45-degree angle endoscope, looking looking left-sided laterally to see the tumor. And again, we're using our very tapered skull base suction to just now using that suction as a between as an instrument to keep palpating the tumor gently, knowing that this much suction force would not really uh, injure or do any untoward complications in the uh, surgical field. So these angle endoscopes can be turned on both sides, and now you see how tumor remnants onto the lateral inferior part of the cellar wall are being carefully visualized and removed using a angled ring curette carefully, with the suction in place to maintain visualization and to remove this. And that is the beauty of the angle endoscopes, because they can manage this step very well. Once a lot of it has been done, we take a little pause to keep a small cottonoid inside this cellular cavity for achieving some hemostasis before we take a call as to whether some more of the tumor has to be removed, or we can call it a day, followed by closure of this defect. So you see here how posteriorly we have practically reached the limit, and we can see the posterior dura here of the sella, which is clean, and that doesn't show any tumor. But of course, there is tumor on the lateral side, on the right side, and we'll see if we can just remove it a little bit of it comfortably without really any attempts to remove every last bit of it, because then that would really be counterproductive. So once we are sure that this is what we want to do and not cause much problems thereafter, use very small pieces of surgicel inside the sellar region, covered by temporarily a wet cottonoid to sort of maintain hemostasis, and with using of autologous fat followed by a flare of fascia to close this defect. The final histopathology of this patient came out to be um gonadotrophin secreting pituitary neuroendocrine tumor, and this patient is presently under considerations for a revision radiation therapy as well as endocrine treatment. A little tissue glue can be placed over the fascia, followed by gel foam patties, just like we do in tympanoplasty and mastoids. To completely set this off, we use Crumber gel foams, and then we again straighten them off, sort of to make sure that this fascia rests nicely.